Thank you all for joining. It gives us a chance to get into a little bit more detail. I hope we can make this interactive. I thought maybe we could start by just going through a few things that didn't have time to cover in the plenary session fully. And hopefully this will spawn some more discussion. So first of all, I just want to remind people that a little bit about gonorrhea biology and pathogenesis, that it is a very humble bug in the sense that it's a gram-negative diplococci. It has particular growth requirements which make it require carbon dioxide. So for those who remember the old days, we used to have chocolate agar plates that we would incubate in candle jars to enrich with CO2. And I think just to remind people too that one of the things that makes gonorrhea the wily bacteria that it is that it has these pili that attach to mucosal surfaces, and that those pili can go through variation which allow immune evasion, particularly of the complement system. But they also provide outer membrane surfaces that we're trying to target for vaccines. Just wanted to remind people of the fact that gonorrhea, I think many of us know this, but just as a reminder that it tends to be, when symptomatic, it tends to be a purulent urethritis, sometimes cervicitis, and we really are trying to interrupt ascending disease with disease of the fallopian tubes. With pharyngeal GC, we touched on this in the talk, but just to remind people that it's very common, asymptomatic, and we probably don't screen for it enough. And it is important because it's a way that you get transmission to the genital sites. Some people estimate that maybe a third of rectal and particularly urethral gonorrhea is acquired from oral genital sex. And then, as I tried to explain, is just we're concerned about it because we think this may be where we know that antibiotics don't achieve high enough levels in the pharynx, so we have pretty high bars for what's considered for the treatment guidelines, that they have to achieve a 95% cure in the pharynx. And there are other commensal Neisseria that live in the pharynx, and they're able to transmit plasmids and other forms of antimicrobial resistance. So this is why we want to diagnose it and treat it, and treat it as effectively as we can. Rectal infection, I wanted to bring up just that, again, remind people that about 10% of MSM will test positive, usually not symptomatic, 85% are not symptomatic, and that it can, prospective studies have shown that it increases HIV acquisition by about 2 to 5-fold. When symptomatic, it's sort of a classic proctitis with lower rectal symptoms with pain, tenesmus, itching, sometimes or irritation, pain with bowel movements, sometimes discharge or bleeding. So when you see it, it can be, you can do, if you do anoscopy, you'll see the friability, sometimes cobblestoning, sometimes purulent discharge, but in 85% of cases, it's asymptomatic. Wanted to remind people that gonorrhea can become disseminated. It's not very common. It's about 1%. We seem to, at least in local experience, it seems to come in clusters where we'll go for years without seeing it and then see several clusters, and it's certain nutritionally deficient species of gonorrhea that are particularly good at evading the immune system. The way you diagnose it is tenosynovitis, particularly in the hands. Pustules, the one on the wrist is sort of classic, where if you unroof it, you'll get an exudate, or on the toe, and then you can get septic arthritis. So something to think about and usually diagnosed through blood cultures and or joint fluid. I touched on this, but just want to come back to it and make sure people understand that the treatment of gonorrhea is evolving. Already, you can see that the doses of ceftriaxone range from the US, which is on the low end with 250 up to a gram in Japan and the UK. We are, this was discussed a lot, STD training guidelines or training, testing and treatment guideline meeting, and there's anticipation that it may change. And as you can see, in some cases where you use higher ceftriaxone, like Japan, they're not using, and in the UK, they're not using azithro. And this is trying to spare azithro exposure so we don't create more problems for ourselves with azithro resistance in Mycoplasma genitalium in part. So GC is one of 5 antibiotic resistant bacterial infections that CDC considers a threat, and they're trying to invest more effort into surveillance. So if you're in a place where you can participate in the SURGE surveillance project, you'll be contributing to understanding resistance because they are doing culture as well as our usual NAT testing. So it's been a long evolution of treatment for gonorrhea. We basically have tried to remove things that don't work and are waiting to see what the CDC will recommend in 2020. And I think that what the future will hold is probably a higher dose of ceftriaxone as we get better nucleic acid amplification tests that can also detect resistance. That might be useful. In the meantime, using culture if you have to use quinolones. And there are tests that are being developed to look at, to give real-time point-of-care results for is GC present, and if so, does it have resistance at this point, looking at quinolone resistance. There's possibility of recycling older drugs like aztreonam or using carbapenems and ertapenem as an example, which was used in the case of some highly resistant drug bugs in Europe. Just touch on a few things about chlamydia. This is an intracellular bacteria that kind of goes into a quiescent phase with elementary bodies and is able to evade the immune system. It infects mucous membrane surfaces, the genital, rectal, eye, and throat surfaces. And incubation is between a week and 3 weeks. And it causes similar syndromes to what gonorrhea does with the addition of a reactive arthritis and also pneumonia in infants. I wanted to just show one example of a urethral discharge, which tends to be clearer, less purulent. You can also get urethritis in women, and about 15 to 40% of non-gonococcal urethritis in men is due to chlamydia. For cervicitis, it tends to be diagnosed through vaginal discharge, which is why the WHO has the syndromic management guidelines are based on vaginal discharge and not on pelvic exams, where it's not always feasible to do. Sometimes women will also report irregular bleeding. Cervicitis is most commonly due to chlamydia, and occasionally, but not by no means always, you will see abnormal cervical findings with a more friability in the zone of ectopy. But the vast majority of people, both men and women, are going to be asymptomatic. You can see conjunctivitis with chlamydia. I showed you the one of gonococcal. Conjunctivitis, chlamydia tends to be less purulent, more cobblestoning, and again, thought to be due to autoinoculation. You can occasionally, but not very often, get oral pharyngeal infection. A true pharyngitis is very rare. And then lastly, with rectal infections, just to remind people that, as we said earlier, it was usually asymptomatic, but you can, just like with gonococcus, get sometimes symptomatic proctitis presenting as discharge or tenesmus. It can occur in women who deny anal sex, thought to be maybe due to oral transmission, but that's still being studied. But just to be aware, it occasionally has been seen in women. And you break chlamydial proctitis down into two types. There's lymphogranuloma venereum strains or non-LGV strains, and they tend to be much more severe when it's LGV, with a true proctocolitis, much more severe symptoms, more clinical findings, and on biopsy you see granulomas. And that's important because you treat for 3 weeks with LGV as opposed to a week doxycycline for non-LGV. Just wanted to remind people that chlamydia not only causes urogenital symptoms, but this is a patient I saw some years ago who came in having been diagnosed with chlamydial urethritis 2 months prior, but he had had sort of a delayed presentation. And he came in with a very destructive arthritis of his second toe. You can just see the color discoloration, as well as the swelling in his second metatarsal. On X-ray, which I don't have, that we obtained, he had a very erosive arthritis, and this turned out to be Reiter syndrome, which you'll see in maybe 1% of chlamydia cases, and required help from our rheumatology colleagues, and he ended up going on methotrexate. So it was no longer an active infection, but more an autoimmune phenomenon from late presentation of chlamydial urethritis. I'm just going to finish up with a couple things on diagnostic testing, and then a little bit on genitalium, and then want to go into a discussion. So just to say that NAT tests are recommended for both men and women. There are very few places where you can actually even get a chlamydia culture now, but through SURGE, the US gonorrhea surveillance system, you can do gonorrhea cultures, and it's actually really helpful for monitoring antimicrobial resistance. Best specimens are first catch urines in men, and vaginal swabs, which can be self-obtained in women. We've now had NAT testing approved for both rectal and pharyngeal testing for the last year. And just to be reminded that currently anyway, we can't do resistance testing on NAT. So to do gonorrhea cultures, ideally through the SURGE program. And who to screen: sexually active adolescents, if they're less than 25 years of age, are recommended to have routine annual chlamydia and gonorrhea testing. Women, if they're older than 25, based on potential risk of exposure through their partner characteristics, and then pregnant women, and ideally to do retesting in their 3rd trimester. For other populations, I think that men who have sex with men, we touched on earlier, to consider more frequent testing every 3 to 6 months if they have higher risk behaviors. And I would include transgender men and women based on if they have higher risk behaviors in terms of number of partners, types of partners, or past STD. And to remember that extragenital screening is recommended for MSM at this point only, because of the relatively low prevalence of extragenital infections in other populations. To be reminded that they're asymptomatic, but still important in terms of transmission and antimicrobial resistance. And we touched on the doxycycline data, just to say that this is something, in my opinion, that we need more data to do, and we are doing the study that is looking at whether doxycycline is safe and effective for STI prophylaxis. We have experience using it for prophylaxis of Lyme disease and malaria. And there's really been no tetracycline resistance detected in chlamydia or syphilis, so we're not worried truly about creating a resistance in these organisms. They seem to be intrinsically not able to develop tetracycline resistance. And we're not really gonna likely do much harm with gonorrhea because it's not a first-line regimen anymore. We use it chronically in persons with acne, and it's not used that often for other infectious diseases. So I think it really is important to see whether we can do something other than testing and treating to try to actually prevent STDs. The study that I didn't have time to show in the earlier slide that was published about 5 years ago came from LA, where they did look at doxy PrEP, not PEP, in HIV positive MSM if they had 2 or more episodes of syphilis. And as you can see, it was really a pilot study. They did see a statistically significant reduction in those who took doxycycline daily, but it was not by any means big enough to form guidelines. And I think there's also concerns about that amount of antibiotic exposure, and maybe post-exposure prophylaxis would be better with less antimicrobial selection and pressure on other organisms, which was the study I presented earlier in EPERGATE, and is going to be, as I mentioned, studied now in both HIV negative and HIV positive persons in San Francisco and Seattle. So once we have about 100 of our 780 participants enrolled, we hope to get reactivated to start enrolling again. We had a COVID pause for the last several months. So if you are able to refer people, we'd really appreciate it, because we think more data are needed on the effectiveness as well as safety, tolerability, and effect on resistance. So we hope in the next couple of years to be able to add to the literature and evidence base to form policy about whether or not this should be recommended. And I think the key thing is that I think Mike Agambrand mentioned this, but it would really be this would not be viewed to be if effective and safe. This is not something that's going to be widespread, but for people who are really at high risk of recurrent bacterial STIs. So stay tuned as we get more data. There's been a lot of interest in DoxyPEP, and we are not having any trouble enrolling. It's just COVID happened, but in a grinder survey we did, as well as in 2 clinic surveys, about 90% of MSM, both HIV positive and HIV negative MSM, are very interested. So they are concerned about STI and want to do something about it. And we need to provide the data as to whether or not DoxyPEP is effective, safe, and what impact it has on resistance. Just finish up with M. genitalium. Didn't have time to go into that, but I think there'll be more guidelines coming out in the CDC treatment guidelines soon. But M. genitalium is really particularly an issue for non-gonococcal, non-chlamydial urethritis, where those who have it have M. genitalium. There's about a 5-fold increase with urethritis. The challenge is just one challenge is treatment. It's not very susceptible to doxycycline, and with increasing azithromycin use, including as co-treatment for gonorrhea, we're seeing more rapid resistance emerging, 40 to 50%. So the alternative is moxifloxacin, but we're also seeing that quinolones can, the M. genitalium can be resistant to quinolones. So what we're seeing in currently in like the Australian and European guidelines are recommending to do testing ideally with macrolide resistance testing. Currently, we don't have those guidelines to do the macrolide resistant testing. So what some clinics, including ours in Seattle, King County, are doing is to treat with doxycycline first, and then to lower the burden of infection, and then to follow with moxifloxacin. So not simple or ideal, and they're really focusing on men who have persistent or recurrent NGU. So stay tuned to see what comes out of the CDC guidelines. We anticipate that probably the guidelines will recommend only testing those who have syndrome. So this would not be a test you do in all comers, but those who have urethritis, cervicitis, PID, and particularly those who have persistent syndromes and their partners. So not a widespread testing or screening program. The evidence is just not there to support it. You just want to guide treatment for those who have syndromes. We touched on this, recommend multi-site screening. And I think in the era of COVID, to try to continue to see persons if they have symptoms, known contacts, if they're at risk for complications in terms of women who have abdominal pain and might be at risk of PID, if they're pregnant with syphilis, any symptoms concerning for neurosyphilis, and routine screening probably should be deferred and used only as, for really high risk persons. So I think I will stop there and invite audience questions and discussions. So I see there's one question about extragenital screening for females reporting unprotected oral or anal sex. And I think perhaps for anal sex, but not oral, the rates of pharyngeal infections are pretty low for those who just have unprotected oral sex. And again, I think what you're trying to do is pick up those who have rectal infections, but the prevalence is still pretty low. So I think that many programs are still not recommending extragenital screening other than for MSM because it's just not cost effective. I see there was another question about finding CT and a PAP samples. I think that is not a reliable way to diagnose chlamydia, and I would repeat a test if you found that. I think that repeat a urine and or vaginal swab to look for it. It's really not very, very reliable through pap smears. Someone else asked, do we recommend urine, gonorrhea, and chlamydia testing or self-swab in women? I think that really it's pretty comparable. So if women can do a self-swab for vaginal swabs, or even tampons have been used, you get very high sensitivity. So I think either can be used. So someone asked about, would you treat an IMGyn partner with doxy, and would you test them as well? I would test before treating because I think we're still learning a lot about the likelihood of transmission, and given the fact that doxy may need to be followed by moxiflox, I would do this based on testing. Someone's asking, for M. genitalium, is UW using single dose 1 gram azithro or extended higher dose like they use in Australia? Is the dose duration of azithromycin for NGU likely to change in the 2020 guidelines? So we are using the 1 gram dose in Seattle, and I think that I'm not sure what they're going to say in the 2020 guidelines in terms of the dose and duration for NGU. What would really be helpful, and I think there's work going on from Hologic, who makes the Aptima testing, as well as another group called SPEDIX, to get macrolide resistance testing for those who are MGen positive. So I think we went through the questions. Why don't people unmute if they want to chime in or have other questions?
Hi, my name's Maddie Ladd from Tulsa, Oklahoma. I just wanted to make a comment about the LGV, lymphogranuloma venereum. We've had a few cases that we've diagnosed different things, rectal masses or proctitis, even a patient who had recurrent fistulas and was seeing colorectal surgery, and many of these cases ended up being LGV, easily treated with doxycycline, like you mentioned, and we do a 21-day course. I guess my question was, because a lot of times patients do come in and they're asymptomatic, and we happen to catch it on a anal pap, or we did screening and found out that they had chlamydia. How many times that you're extending that treatment, or do you just do the doxycycline for 7 days, or in certain instances maybe go ahead and increase it to the 21-day? And I know compliance is affected when we're increasing it to 21 days, but you know, the hopes that they at least get the 7 days in for the treatment. But just any thoughts on that? Are you pretty lenient in extending it to 21 days, or only if they're symptomatic?
Yeah, we tend to are doing just 7 days unless they are symptomatic, and ideally then would do anoscopy to try to see whether there's any evidence of proctitis. Yeah, I think it's just in general, prolonged courses of treatment are, you know, I think we have plenty of experience in other areas of ID as well, where people are not motivated to continue taking antibiotics that long if they're not having symptoms. So really would restrict it to people with symptoms. So in the cases, can you just comment a little bit more on the cases? I'm sure people who haven't seen LGV would like to hear a little bit more about the cases that you're talking about. Do you think that the diagnosis hadn't been made earlier, or are there any teaching pearls from these cases?
Sure, absolutely. I mean, it's definitely been a learning experience for myself, but it's been several years since the first case, and this is when I kind of started looking into it. But the first case, actually, a patient who was referred because of symptoms to the gastroenterologist, and they ended up doing a colonoscopy and found a rectal mass and didn't know the etiology of the rectal mass. And the gastroenterologist had been in practice for quite a while and said, you know, this is a scenario. He's like, I've seen it once, but it ended up being chlamydia. And they wanted to know how to test for it. And, you know, we went through, okay, well, we need to get swabs, and ended up being chlamydial proctitis. The rectal mass completely resolved once they were treated with the doxycycline. So that was actually the first case that I experienced. And then since then, now just having a higher index of suspicion, we've had many other cases. The second case, well, I think it was maybe a year later, but a patient who had been referred to colorectal surgery for fistulas, again, continued symptoms, anal discharge, you know, different things that were going on in terms of his symptoms. And he was already seeing colorectal surgery, and he came in, and I saw the patient, and I said, you know, we've got to make sure that you don't have chlamydia causing these symptoms. And we went ahead and decided that we were going to treat for doxycycline for 21 days, even before testing was back. And then testing did show that it was chlamydia. And he had complete resolution of his symptoms after the 21 days of doxy. This patient had several visits with colorectal surgery, and they were trying to treat his fistulas, and the doxycycline for 21 days completely cleared his symptoms. And he'd struggled with it for a while. So those were probably my two learning cases about LGV. It's definitely out in the community. We have an infectious disease, we're in Oklahoma, and we have an infectious disease that's practiced in New York, and he said he had clinically seen quite a few cases and treated.
Mm-hmm.
So I think it was just getting underdiagnosed where we are. And now that we know what we're looking for, we've been able to diagnose and treat a lot of patients with this.
Mm-hmm. And can you just comment on how were you able to confirm that it was LGV using complement fixed tests, or how did you
No,
convince?
actually, no, we just ended up actually treating, but I would love to know a little more information about that.
Yeah, so that is one of we don't have a great commercial assay for LGV serovars, and so really your choices, I think that in the right clinical syndrome, having PCR positive for chlamydia is a presumptive diagnosis. You can order complement fixation titers, which are done to the different serovars, but that would be a send-out test through your lab. And it is useful because it is a reportable disease, and I think helpful for us to just better understand the epidemiology and track what we're seeing.
Okay, perfect. Thank you.
Sure.
Hi, Dr. Kim, can you hear me?
Yes.
Hello? Oh, Dr. Rosado from Salt Lake City. I am concerned about
Not hearing you very well. Could you just speak up a little bit?
Can you hear me now?
Yes, better. Thank you.
So a patient with single positive test for chlamydia, gonorrhea.
I'm not hearing you very well. Could you write your question or make your comment in the chat box? Are others able to hear him? No. Okay.
I can't hear him either.
Okay. Harry, I don't know if you could hear me, but please make your comment or ask your question in the chat box.
Well, we're waiting for that. Is there any topical recommendation for gonorrhea of the eyes along with the ceftriaxone?
No, I mean, we did give him, I think the ophthalmologist gave him drops, but just partly it was to clear out the exudate. But he responded very, very quickly to the IV ceftriaxone. But it was very perplexing and not very satisfying that we couldn't get a clearer understanding. I should maybe have mentioned sometime during this that I think the Australians really believe that pharyngeal gonorrhea is important in terms of transmission, and since that was his only history, at times it was hard to believe because it had happened. His last episode of what he called deep kissing was like 3 weeks before, and the incubation period didn't quite make sense. But this is the joy of clinical medicine. You have to accept what you can get from patients, and it's possible, I suppose, that he had pharyngeal GC and had somehow auto-inoculated, but it was a pretty dramatic case. So Harry, I see your question. You're asking if someone's chlamydia positive in the throat, would you treat? And I would. I think, again, it's partly this idea that there is oral genital transmission. I feel like we know less about that for chlamydia than gonorrhea, but I think that in the context of a sexually active person who has chlamydia trachomatis in the throat picked up by PCR, that I would treat. So Ken is asking, first void urines are recommended for GC chlamydia screening. Clinically, we are not able to do this. Are we missing asymptomatic cases with random urines? So not completely clear why you can't do first void urines, but maybe you can clarify that. The sensitivity is a little less with the random urine, but it's still quite quite high. So I suspect you're not missing many, but if possible, instructing people to do first void urines would be the best. Gita has a question about a 19-year-old woman with lupus for whom the rheumatologist checked an FDA antibody, which was positive. She was sent to my colleague who checked an RPR, and this was negative. She reports being sexually active, but no known history of syphilis or being treated in the past. Please advise if this could be a false positive. I know it is not the normal sequence of testing for syphilis. And I think it could be a false positive. I think there is a literature from lupus and rheumatoid arthritis that you can get cross-reacting antibodies. So I would, I think I would follow in this case, the RPR for evidence of active syphilis. Other cases or discussions that people wanted to have?
I have a question about alternative treatment for gonorrhea. Currently, we're primarily using gentamicin 240 milligrams IM plus 2 grams of azithromycin single dose. Since we seem to be moving away from dual therapy for gonorrhea, and how do you think we'll be handling patients with cephalosporin allergies? Would we be using gentamicin monotherapy or continuing to use the dual alternative therapy, or will we be referring more people for desensitization? I just wondered what your thoughts were on that.
Yeah, that's a great question. I think that CDC is going to emphasize desensitization more. I think that one of the challenges is that you don't, with aminoglycosides, well, first of all, it's not always easy to be able to use them in some settings, depending on where you're based, and that the levels are also not necessarily high enough to get good treatment of pharyngeal GC. So I think that desensitization is going to become even a bigger emphasis.
Speaking of desensitization, I understand that actually the cross-reactivity between penicillin allergy and ceftriaxone is rather low.
It is.
So do you know if recommendations are for us to test in the office, or, I mean, sending everybody to an immunologist for this process could be a daunting task, particularly in rural areas?
Yeah, really good question. So I think you can do, there are protocols for being able to do it in the office, desensitization but to your first point, probably 90% of what people say are penicillin allergies are not. So you really have to take a history. Sometimes it was ampicillin when they were a child, and they've since had penicillin. So I think being a little bit circumspect about penicillin allergies, and then if they have a bona fide allergy still, there's probably the data suggest it's a pretty low rate of cross-reactivity, 10% or so. So I think if you are able to do a rapid desensitization in the clinic, that would be the best option. I really don't think you need to send most people to allergists to do desensitization. Someone asked, how comparable is a urine gnat and a vaginal swab specimen? They're highly comparable. So I think that you can rely on urine gnats for screening for gonorrhea and chlamydia in women. And someone asked, will my slides be posted on the website? Yes, they will. Someone asked, how long after infection would the gnat be expected to be positive? So for gonorrhea, it's on the order of about 14 days. For chlamydia, about 20, can be out positive even after effective treatment with a negative culture out to 28 days. I guess one question I would have for you all is, are any of you doing, just for a cost purpose, putting 3 swab, basically pharyngeal and rectal swabs into the same NAT tube to save cost of multi-site testing?
That's an excellent suggestion. It's like pool testing for gonorrhea.
Right, right.
Yeah, interesting.
But Dr. Celum, can you hear me now? That is, then you don't know. Can you hear me now?
A little. You're breaking up, Harry, but I can hear enough that maybe I can answer.
So if you do pool testing, you don't know which one is positive.
Sorry, Harry, I can't hear you. Can you type the question? And then while you're typing, I'll answer one from Winston. He was saying, how long after exposure or initial infection would you expect to pick up GC or chlamydia on that? So for GC, it could be as short as a few days, but chlamydia, the incubation period can be longer, so out to 21 days. And some of this comes from studies that were done some years ago. Jeannie's asking, what's the source for the poster for self-swabbing? That is through the STD training centers, and if you email me, I can put you in touch with Amy Radford at the Regional Training Center in Seattle, who can send you PDFs of that. So Lily's asking, if you do 3 swabs in 1 tube and the test is positive, how do you determine where the infection is? That is the limitation. You wouldn't know. But, and I think that it's something I wouldn't do as your first course, but I think if it's a choice of not being able to do it due to cost of testing, that some people are promoting that. So I asked the question not because I'm recommending it, but just because I'm curious if it's actually happening in practice. I think I would agree that if you're able to, if cost of testing is not a factor, it'd be preferable to do the single site testing so that you know the location and can follow that if you do a point of care test. So any other people want to present any other cases or conundrums? I guess a question for all of you. Are you seeing, I guess this is an impressionistic question, but is your sense that COVID has really changed people's sexual activity? Are you having fewer of your patients who've had past STDs coming in for STI screening? What is your impression? So Winston's saying that the STD clinics are seeing about 50% of the patient volume that they normally see. And I think that is what other clinics are seeing as well. I have to say it's in the patients I've talked to through telemedicine, it's when we had initially not had people come in the early days of COVID for self-testing. A number of them were not happy with that option, and we're now seeing more people coming in for doing that. I think it's become kind of a peace of mind for them, as well as a way to guide our therapy.
Question I would have to follow up on that is that, are people socializing less, or are you hooking up less, or are we just seeing less of them because we can't provide the access?
It's a really good question. I do not know. I mean, my impression, and this is totally impressionistic from just some of the discussions we've had with MSM and our DoxyPEP study, is that people have had fewer sexual contacts. Whether or not that'll continue to be the case as we have longer periods of social distancing and public health interventions for COVID, we'll have to see.
It seems to me that they may be engaging more in sex with their regular partner rather than diminishing the risk, rather than they are locked up with them, and basically, and as many of my OB-GYN partners are saying, we're going to have a baby boom in about a few months. But I don't think people are abstaining, but I think the risk may have diminished because of the epidemic.
Yeah, yeah.
I actually have a question about diagnosis codes. So I have a fair number of patients who are doing their best, and especially a lot of trans women who have been in a new monogamous relationship for 1 month, but and they're being smart, but I still really think that they need to be screened a little bit more regularly because of past partners. And in someone I know well, I can just explain the high-risk sexual activity diagnosis. That's usually going to get it covered, especially if it's multi-site. But I still don't always love using that diagnostic code to get some of this testing covered if it's more because they sporadically have a new partner every now and again, if I'm doing more frequent testing. Does anyone have, for specifically STI testing like this and the multi-site testing, any diagnostic codes that are a little bit less stigmatizing and a little less offensive if it's on the diagnostic sheet that will still get some of these covered?
Does anyone have an answer for that? It's a good question. I agree that sometimes I hesitate ticking that box and knowing that as people have more access to records, but I also know that insurance coverage is important, so you have to sort of weigh that. And I think that sometimes having a discussion with your patients about it, just say that this is, you know, I feel the same way when I have to tick HIV disease versus HIV infection. But I think I work in a pretty underserved population too. So I think the insurance coverage is really important to the clinic and the patients. So there are several comments coming in the chat box. I'd be interested to hear from those who put them in about the challenges with having coverage of more testing more often than annually. Can someone speak to that? I think for us locally, having local guidelines that recommend quarterly testing for people who have more exposure has helped us avoid this. To my knowledge, we're not having issues with Medicare coverage, but I'd love to hear from some of the people in the chat box who are commenting on that. Do you have local guidelines? Do you think that would make a difference in terms of pushing back on Medicare and other payers? And I would also think that with STD guidance from CDC recommending more frequent testing, that would also be another thing that you could say and contest some of these charges. So I think someone, just going back to another question a little ways back, someone was asking about trichomonas. We have only been doing trichomonas testing in women with vaginal discharge, and occasionally in men with urethritis if we don't have another etiology, but not doing it routinely.
There particular
This,
reason, Dr. Cullum, why you're not testing for trichomonas? I am working in the Metro Philadelphia area, and we've seen an uptick in the trichomonas cases within our patient population. I don't know if it's because we're screening more. You touched to that.
Yeah, are you seeing, what patient population are you seeing?
MSM, women who have sex with men, are like our two biggest populations that we see in clinic.
Well, it's pretty rare to see it in MSM, and I think really so I think your yield is going to be low, particularly in MSM, but I think for women who have symptoms of vaginitis, then it makes a lot of sense. And it has been reported in male contacts to cause, of women who have trichomonas, to cause urethritis. So I think if you don't have another etiology for urethritis, it makes sense. But do others want to comment? Is that different than your practices? Okay. And I think someone is saying some commercial labs are now doing trick testing as well as chlamydia and gonorrhea. You may sometimes get it even if you don't order it. And if you do, if it is found, I would agree that I would treat it. I think the data, one of the things that'll probably be updated in the CDC guidelines is to not use single dose metronidazole, but to use a week's course of metronidazole for trichomonas. So stay tuned for that.
this is Dr. Quero, getting back to the issue of getting the screening tested. I have this problem, have had it perennially. And at one of our conferences a couple of years ago, somebody suggested that instead of screening for STIs, we use the code, which is a Z20 code of a contact or exposure to an STI. And that seems to go through better as far as the payers go. Not 100%, but I did have some success with that.
Okay, that's great. Thank you.
I've used that a little bit. I think my biggest struggle is the specific patients that I have in mind that I do this often for are also the ones that are at such high risk of intimate partner violence that I really don't want that on their paperwork either. So I have trouble, like, sometimes I literally just print their paperwork before I put the diagnosis code, but that's the best I've been able to come up with, just because I just feel like there's no good terminology for that instance.
Yeah.
Yeah. I don't know if everyone has their chat box open, so I'm just going to highlight a couple of other comments that, first of all, Fatima tells us we just now, I guess, have about 5 minutes left. So it'd be great if people have any other questions or cases they want to present, but also just to pass on a comment from Rachel that's, she's saying in their clinical setting, they're not routinely screening for trick because it doesn't have significant clinical implications. And I think that is it's true that vaginitis is, I mean, it can be, obviously, if it's symptomatic, it can be bothersome to women. Sometimes can also cause cervicitis and occasionally urethritis, but it's in many people, it's going to be asymptomatic. So I would agree that it doesn't make sense to do widespread screening. So Fatima is telling people to return to the platform that there will be a 15-minute break, and the opening plenary, which sounds like it'll be great, is set to start at 1:30 Eastern time. So make sure that you're back for that. So maybe just a last call for any comments or questions. You guys have been great. I really thank you all for being part of the breakout group and for doing the work you're doing. I think it's a time where we need to really remind ourselves that this is important work. It's challenging, particularly in the era of COVID, and it motivates me to see the motivation of my colleagues to continue to do work on HIV and STDs. I feel like STDs sort of got a short shrift with all the emphasis on HIV, and they hopefully will put some more energy into finding new interventions, be it Doxypep or meningococcal vaccine, and there's actually work on both syphilis and chlamydia and herpes vaccines that are going on. So stay tuned to this space, and hopefully we'll have more to talk about and more to celebrate in the future. Winston, I think you had a question about 1 week of metronidazole for trick. My understanding is they'll be recommending it for all women, not just HIV positive. But again, check the guidelines because they have not been released yet and should be soon.
Well, thank you for your leadership, your support, and all your wonderful lectures. We've appreciated it.
Thank you. It's been a real pleasure. Now you get a bio break and then a great plenary. So take good care, stay safe and healthy, and keep up the good work. Thank you.